Okay, now you are live on YouTube and we can start.
Hello, everyone, and welcome to the Congenital Heart Academy session. We're doing a case-based fetal cardiomyopathy spectrum and evaluation, management and outcomes. And it's my pleasure to introduce our team who have been quite interested and have been evolving both diagnostic algorithms and management algorithms of affected pregnancies. I'm Lisa Hornberger, and I have been in the field for many years, probably well over 3 decades. And I'm Divisional Director of Pediatric Cardiology at the Stollery Children's Hospital and one of the executive team leads of the Stollery Cardiac Center. I'm joined by my colleague, Dr. Luke Eckersley, who's a fetal and pediatric cardiologist at the Stollery. He's Associate Professor of Pediatrics at the University of Alberta. He's our Director of Pediatric Cardiology and Patient Services and has been very much interested in research areas within our field of fetal and perinatal cardiology. Dr. Shilpa Maratha is a pediatric and fetal cardiologist who's trained in India, Australia, and most recently with us in Edmonton, Alberta. She's back in Brisbane practicing, and she has a particular interest in fetal hemodynamic assessments and is actually currently working on the second arm of the Fetal Heart Society fetal cardiomyopathy study, reviewing fetal and neonatal echocardiograms. Dr. Simon Urschel will be on very shortly. He is a heart function and transplant specialist. He's professor of pediatrics. He directs our pediatric cardiac transplant program and has held many national and international leadership roles in pediatric transplant medicine, and including currently on the board of directors for the IHSLT Society. Dr. Shiv Chandra is a maternal fetal medicine specialist and associate professor in the Department of OB-GYN here at the University of Alberta. She's held several administrative roles, leading MFM, as well as a program director for training, and is currently chair of the MFM Specialty Committee of the Royal College of Physicians and Surgeons of Canada, and a member of the exam board. Dr. Owado Calasirio is an associate professor of medical genetics at the University of Alberta, and in fact is our corridor clinical section lead, so is a regional lead. And she's worked very closely, not only clinically in the prenatal counseling area for pediatric cardiac and fetal cardiac pathology, but actually also has worked very closely with our team on this Fetal Heart Society cardiomyopathy, fetal cardiomyopathy study, and has actually been the lead geneticist for the study. And finally, last but not least, Dr. Michael Van Menen is a neonatologist, but also importantly, the chair in health ethics, the director of the John Dosseter Health Ethics Center, and a professor in the Department of Pediatrics at the University of Alberta. He's had clinical practice as a physician in neonatal and perinatal medicine within our hospital. And his research has primarily been directed towards relational ethics, situated within the tradition of phenomenology. This is definitely not my area of expertise, but so he's going to wear two hats: that of the ethics part of it, which is often comes to play in these very complex patients and high acuity patients, but also the neonatologists. So with that, we're going to start with 4 cases and then run through the findings of a hot off the press fetal cardiomyopathy study that represents collaboration of many centers within the Fetal Heart Society, that will go through some of the findings, and that was spearheaded by Angela McBrien. I'm going to start with Luke Eckersley, who will present our first case. After each case, we'll do somewhat of a discussion. If you have questions, please put them in the Q&A. We have some questions as well prepared that we can work through as well. And then we'll go through the findings of the study and then have another opportunity for questions. So please feel free to put your questions in the Q&A. Many times questions that you have will probably be questions that others have as well. So really important to get those questions out. So Luke, why don't you take it away?
Okay, thanks, Lisa. So case 1, an obvious problem. So this is a 26-year-old G1P0 mother who presented at 23 weeks with an abnormal heart suspected on a mid-trimester anatomy scan. There was a negative family history, no unknown consanguinity, but they were from a small rural town. And then this is some selected pictures from that study. So you can see on the image on the left side of the screen, a four-chamber view, and sentient features include there is a cardiomegaly with the heart taking up more than a third of the chest, and then the systolic function is bilaterally decreased, and there's hypertrabeculation of both ventricles. So you can see that the rather than the usual smooth-walled left ventricle on the left side of the screen here, there's some additional trabeculations, and likewise on the in the right ventricle, which is albeit usually more trabeculated. On the right side of the screen, we can see that there's a short axis view, so left ventricle at the top of the screen and right ventricle at the bottom. And this again just demonstrates that there is a significant reduction in the systolic function. Moving on to a color image. So this is again a four-chamber view. We can see now that the left side of the heart is on the right side of the screen. So here we can see that there's fairly significant tricuspid regurgitation, and you may also have noted that at the apex of the heart there is a to and fro flow and a suggestion of some dropout in the septum, raising the suspicion of a ventricular septal defect, although this is probably not the best angle to see flow across that because it's perpendicular to the probe. On the right side of the screen, we have a three vessel view with color. So we have PA, aorta, and SVC. So you can see there's antegrade flow, so away from the probe in both the ductus arteriosus and the transverse arch. But you also may notice that there's some regurgitation from the pulmonary valve. And there's something else on here, but I'm just going to leave it to see if people pick it up. This is another four-chamber view just showing again that there's some tricuspid regurgitation and that flow at the base of the heart. And here you can more clearly see that there is a ventricular septal defect at the apex, or at least one. And last but not least, there's a sweep up from the four-chamber view cranially, and the thing that I mentioned earlier, interestingly, this baby, although has otherwise normal intracardiac anatomy, has a right aortic arch and a right duct. So both the arch and the ductus arteriosus. So arch coming around here and here, and then the ductus arteriosus heading straight back, are both to the right of the airways. So a bit unusual. So we always do Doppler assessment in this situation. So the findings that were relevant to this case were low velocity hollow systolic tricuspid regurgitation. So whenever we see low velocities, it can be an indication of poor function. The IVC Doppler and the ductus venosus Doppler were relatively normal. And some additional things that we like to do when there's a cardiomyopathy suspected are these, and we look at the ventricular filling actually standardly on all cases. So in this case, we found low mitral valve and tricuspid valve EA ratios, which can suggest sort of restrictive physiology. The isovolumic relaxation time was prolonged. And then from a systolic perspective, both of the LV and the RV fractional shortening were reduced, confirming the sort of qualitative assessment of systolic function. The isovolumic contraction time was long. Interestingly, the combined cardiac output was thought to be still normal. And then more global measures, there was no hydrops fatalis seen. The TAE indices were elevated, so sort of global systolic and diastolic function measures. And the babies had a femur length which was measuring several weeks shorter than the BPD, which was closer to the sort of the gestation. We calculated a cardiovascular profile score just for those who aren't as familiar with this. It's calculated as a normal score of 10, and then points are subtracted for various elements of fetal compromise, so venous Doppler changes, heart size, cardiac function, and arterial Doppler changes. So in this case, our baby lost 2 points for a large heart and the holosystolic TR with, as well as that, the reduced shortening fraction. So moving on to counselling. So we thought that this was most likely a non-compaction cardiomyopathy with moderate tricuspid regurgitation, moderate left and severe right ventricular systolic dysfunction, and some early or sort of more subtle diastolic changes. There was also a finding of multiple apical muscular VSD, so a Swiss cheese septum, as some people call it, and right aortic and ductal arches. So the combination of these findings suggested potentially a genetic syndrome, and genetic testing was therefore urged. We also recommended parental ECGs, echocardiograms, and we offered maternal digoxin, which was declined at this point. From a prognostic perspective, we counseled that there was a potential for progressive dysfunction, and hydrops could evolve, and that close monitoring would be required during the pregnancy. We would usually plan to deliver babies of this type at around 39 to 40 weeks at the maternity hospital, and with fairly prompt transfer to our pediatric cardiac care. I should say that we also often consider whether the baby would require delivery at our actual surgical site, which I'll talk a bit about. So, and then there was a discussion for how ventricular septal defects might need to be closed, so either with a 1 or a 2-stage repair, and that it was unclear what the pre and postnatal outcome would likely to be, given that there was this concern about genetic diagnosis. So therefore, the potential for things like early demise and need for transplant would be dependent on genetics. In terms of follow-up, there was a maternal fetal medicine assessment the next day, which found a large head which was abnormal in shape, possible absent cavum septum pellucidum, with an MRI recommended, also declined at this point, and suspicion of mildly short and long bones. And pregnancy discussion options were again discussed. There was a genetic assessment, which, as I said, no relevant family history, but an amniocentesis was performed showing a normal RAD and microarray. So we followed up the baby, and over time we noted that the aortic isthmus was potentially showing some signs of progressive hyperplasia without an obvious posterior shelf to suggest a definitive coact. So for that reason, the prostaglandins were planned to be commenced at delivery. We continued biweekly surveillance, and that showed essentially that there was mildly worsening biventricular systolic function, but no progression in either hydrops or diastolic dysfunction. The cardiovascular profile score declined further to 6 due to a large heart and the uniphasic inflows, so a slight progression in the diastolic dysfunction, but there was adequate fetal growth. We did, as I mentioned, discuss this at our cardiovascular surgical conference, with regards to whether the consensus was that delivery at the surgical site would be required, and at that time it was not felt to be necessary, but a discussion about whether we would offer ECMO postnatally was had at that meeting. Palliative care team, our assist team, were also involved, and the conclusion was that the family wished for a middle path, so no ECMO or VAD involvement, but otherwise complete, or whatever we could offer. A fetal MRI was then accepted by the patient, and that did confirm that there was agenesis of the corpus callosum. So we always hold multidisciplinary meetings involving our neonatologists and obstetricians, as well as the cardiac team in complex cardiac cases. 2 were held in this case at 32 and 35 weeks, and the plan was for induction of labor at 36 weeks due to the large head size and the patient wanting a vaginal delivery. So this is what things look like after birth. So this is the last fetal echo, and you can see again that so we have left side here and right side here. We can see that there's definitely hypertrabeculation of both ventricles. You may notice that the rhythm here is not completely normal. It's maybe an ectopic in there, and that there's significant number of ventricular septal defects in the apical segment of the septum here. Postnatally, this is what it looked like, and it looks very similar, again with quite a few holes in the base of the septum and bilateral dysfunction. And just a parasternal long axis view that sort of just confirms that and shows the ventricular sort of dilation as well as the hypertrabeculation and dysfunction. So what happened? So the baby was born at 36 weeks, had a vaginal delivery with induction of labor. APGARs were 3, 6, and 6. The baby required intubation, inotropes, and Proston, and was transferred to our surgical center. The inotropes were able to be transitioned to heart failure management with ACE inhibitor, DJOX, and diuretics and fluid restriction. Proston was able to be turned off when it was confirmed that there was no posterior shelf. And a transplant workup was initiated. From a respiratory perspective, the baby did require over the coming weeks invasive and then non-invasive ventilation, but we were never able to completely wean the baby off non-invasive support. A whole genome sequence was performed and returned no-no syndrome, which is an X-linked condition which is associated with non-compaction cardiomyopathy, intellectual disability, facial dysmorphisms, and other CNS abnormalities. Unfortunately, this neonate and infant declined over the coming months, and with the family's wishes for no invasive support, was transitioned to comfort care and demised at 78 days. So I'll hand it over to the panel.
Great. Thanks, Luke. If there was one comment, Wes should have been offered with the amniocentesis, so I thought maybe I would ask Awana, who's a medical geneticist and very involved with our cases, maybe to talk about sort of the approach to genetic testing and some of the issues, perhaps in terms of timeliness, and finally, also a little bit about no-no.
Thank you, Lisa, and thank you, Luke. So when we get involved with the fetal echo group, it's in the prenatal setting. We are part of this multidisciplinary group. And from our perspective, and it has become more and more the question from the rest of the team, is the patient having a genetic disorder, and what is the extent of this genetic disorder? Because obviously, when there are plans for management, postnatal management, prenatal, postnatal management, it is important to look at the patients not from only the cardiac standpoint, but actually the person as a whole. So for us, obviously, it's also important to perform genetic testing, which supports our diagnosis. Here, there was a suggestion prenatally of a syndromic presentation. At the time, we did not have access to whole exome sequencing prenatally, so that's why there was limited testing as happened at that time. And the rest of the test was completed postnatally, as you heard. So this no-no syndrome is a condition that is one of the many thousands of genetic conditions discovered in the last decade. The first cases were described to children, actually towards adulthood, actually, in 2015. And these were two individuals, two males, as we said, it is an X-linked condition with severe global developmental delay, intellectual disability, dysmorphic features, and a number of other features, but no congenital heart defects. Over time, as more cases have appeared, the phenotype and the expansion of phenotype has happened, which usually is the case. And now we know that there are cases who are actually lethal prenatally, and the other end will be, from your perspective, cases with no congenital heart defects. So the importance of having a team is to understand this disorder deeply. And obviously, when it comes to parental counseling, there is, again, a team effort, and we all bring our piece to this big puzzle. So the importance of having registry is also that to understand a natural history of these conditions, which are very rare. There are very few cases. At this time, probably less than 50 reported around the world. We have a recent paper where we were able to collect 16 cases, and perhaps that sounds little, but in our field, that's the reality. So
Right.
I don't know if
That's
there are other questions, I'm happy to answer.
very helpful. Michael, you had maybe a comment, and I was going to ask you anyways, a bit about sort of the preparation for these babies as a neonatologist, and then also when to get ASSIST involved
For
with
sure.
these complex lesions and uncertain futures.
Thank you, Lisa. I was just reflecting on this case. When Luke, Dr. Eckersley was presenting, he used the phrase, the patient wanting a vaginal delivery. And I think we have to remember these are really challenging pregnancy decisions for families where we're trying to respect the mother's bodily autonomy, their values, their beliefs, putting those forefront, recognizing that we also need to come up with a plan to care for the baby after it's born. So really these kind of pregnancy decisions benefit from continuity in care in the sense of delivering consistent messaging, yet at the same time benefit from different perspectives and expertise. So we lean on each other, I think it's fair to say, during these consultations before delivery, recognizing that the geneticists, pediatric cardiologists, neonatologists, social workers, the maternal fetal medicine specialists, and I can go on, all bring very important perspectives to try and support a family in coming to these decisions. I also reflect on this case that this family is from a small rural community. And for many of these families, much of this information can be very foreign information. Even families that do come from urban centers or families whose parents have high degrees of education, these are rare and unusual conditions and are much to come towards. So there's an ethics with regards to how you communicate, navigate situations of uncertainty. Special care has to be taken when we try and walk this middle path. So when a family says that they want us to do something, but not so-called everything, meaning that limitations like in this case are placed on using VAD or ECMO, sometimes we can run into this so-called Goldilocks effect or phenomenon, where essentially the family will choose that middle path because it seems reasonable as something to offer between its dreams. Yet, a child who spends 78 or 79 days of their life in an ICU environment, that isn't necessarily an outcome that isn't without potential harm for what that child lived through as we're coming through these decisions. So I guess I'm just trying to reflecting as both a neonatologist, as someone who's interested in ethics, that these are very complicated pregnancy decisions. They're complicated neonatal decisions, they're complicated lifelong decision making, and they really benefit from that team perspective.
Thank you. Yeah, I think that's going to be key all along, and you'll see, and unfortunately, Dr. Chandra, our maternal fetal medicine faculty, was having some challenges with her internet. One other question is for Sue, and that is sort of I should just say that the whole team effort is actually critical in all of these. I mean, where you're talking especially about these high acuity patients, it's not just even the fetal neonatal team, it's also even pulling in colleagues, our surgeons, our cardiac intensive care faculty, other heart function transplant faculty, and other cardiologists to really come together and say, and anesthesiologists to say, what are we doing for this family? Where should we be delivering? What sort of things should we be thinking about post? And actually also having these discussions with families up front so that it is not a shock once this baby's delivered. There's already sort of a slow pathway towards what's to expect for this baby, what are the uncertainties, what are we going to be able to offer, and such. So just briefly, if you can tell us how you guys, from the MFM perspective, when you kind of are planning delivery, planning surveillance and delivery, what are the sort of things you think about? What is the sort of approach generally?
Right. So assuming, we did a comprehensive ultrasound, that there were no extra cardiac anomalies in terms of surveillance for those patients that are continuing the pregnancy. Mainly our main tools of surveillance are biophysical profiles, as well as assessment of fetal growth and arterial and venous Dopplers. And in terms of using those surveillance techniques, it really does help inform timing of delivery as well as mode of delivery, because as you can see in this case, we did find that the head size was informing a little bit about delivering slightly earlier because the patient did want a vaginal delivery. And at a certain point, the head circumference will make it not possible to deliver vaginally, potentially, just because of the physics of the maternal pelvis and as it relates to the fetal head and molding. So that's one thing. So growth is important. Assessment of fetal well-being is important. And then in terms of mode of delivery, primarily other than kind of physical things like size, the surveillance with biophysical profile and non-stress tests will help us know whether the fetus has reserve to tolerate contractions for labor, because when the fetus is at rest is one thing, but labor is actually stressful for any fetus. So we use arterial and venous Dopplers as well as our non-stress tests to help us look at that. And now with cardiomyopathy, we know that the ductus venosus can be a little bit difficult to interpret, like which part of that is cardiac, which part of that is fetal well-being. So I think that's where the arterial Dopplers of the cord and the middle cerebral artery, as well as the biophysical parameters and the non-stress tests help.
Great, thank you. I'm sure there's a relatively low threshold given potential risk if there is biventricular dysfunction, and especially involving hydrops for a cesarean section. But again, that is something that really needs to be discussed with the families and making sure, as Michael emphasized, that it's what their goals are, and making sure that we're really following what's right for them, along with what's right for their baby. So thank you. And finally, one question that came up was family cascade testing offered and done. It's always interesting and complicated when there's no family history of X-linked affected family members, leading to the question of penetrance and expressivity. So I'm going to leave that one to Oana.
Yeah, so in a case like this, obviously we focus on the patient that was in an ICU, but we also think about the family, because there is a future to every family that we hope. And that includes familial testing. In an X-linked disorder, obviously, we think that the mother may be a carrier, and that obviously has implications for her reproductive plans. And here was the case, that was the case, and then there is a risk for this situation to repeat in a future pregnancy. So we'll want to prepare the couple for and make a plan for the next pregnancy with the possibility of prenatal diagnosis if the couple is interested. Now, this was a very challenging case. Obviously, for any parents who have a child that's so sick and who dies, it is a extremely defining moment in their life, not just in that moment, but for the rest of their lives. And many times that communication and follow up and plan for a next pregnancy may not happen, just because they don't feel prepared to actually think of a future, or maybe of a better future for the moment. But many times we encounter these couples when they come back pregnant. And then obviously there is a bit of a pressure in trying to think, do we want to really focus on this possibility of a repeat of the situation that they have encountered before, or they just want to continue with the pregnancy as it is. We have not encountered this couple back. Actually, she came back once, but she did not want to meet with us. And that is also a possibility. We know that happens. But at least they meet with our colleagues in MFM. They meet with fetal echo. And that's very important to assess the fetus.
Great, important points. And we'll have opportunities to discuss a bit further some of these areas with subsequent cases. For the sake of time, I'm going to move on to our next case, and I'm presenting that one. And let me just find my share. I don't know. Yeah, there we go. And hopefully you're seeing, and I just got to, my apologies, got to move ahead. I didn't get it prepared. There we go. Case 2. This is sometimes they can be subtle. And this one, honestly, it's I think the fact that it was identified by our obstetrical colleagues during a screen for something else in the baby makes you just a bit anxious just about these sort of diagnoses. So this was a 38-year-old mom, a gravida two para 1, who had gestational diabetes. She presented to us at 28 weeks with a bit of an abnormal or concern about the heart on obstetrical ultrasound. And again, there was a negative family history. She had had a previously healthy child delivered at term. This is what we saw. The heart's not particularly huge. It's maybe a little bit generous, but really borderline. But what we were seeing was that the right heart didn't quite squeeze as well as the left, and even the left didn't look fantastic, but it was squeezing better. And so it was the sort of subtle findings that led her to be referred, which I was really surprised. But it's part of the screening should be looking at that 4-chamber and looking at the squeeze, and the squeeze of the ventricles should be pretty symmetric. So that's something really important that should be part of every fetal cardiac screen. So this RV was not functioning very well. The LV a little bit better, but still not perfect. And you can see from the short axis, and hopefully you can see this, there's a little better function of the LV, but in the short axis, the LV also didn't look fantastic, and the RV looked terrible. So it's kind of interesting. And of course, the first thing you're going to do is make sure the ductus arteriosus patent, make sure that there's no pulmonary outflow tract obstruction. So the usual things that you'd think about right away, but there was none. In fact, the most we saw was maybe a little bit of a dysplastic tricuspid valve, a little bit of kind of a stiff-looking septal leaflet, and a little bit of tricuspid insufficiency. But otherwise, there wasn't anything really definitive. Of course, we like to see that there's not really high pressures on the baby, and tricuspid or mitral regurgitation can be very telling of what else is going on in the system or in the placenta as well, with much higher velocities than you would expect for the blood pressure of a baby of that gestation. And roughly, it's about a millimeter per week of gestation. So at this stage, she's almost 30 weeks, 30 millimeters of mercury is probably roughly an average systolic systemic blood pressure. And maybe this was a little bit higher, but not dramatically so, not like what you would see, say, in a twin recipient baby. So there was whole systolic TR and a gradient that suggested RVSP being about 36 plus the atrial pressure. There was also the inflow of the RV was definitely not normal. It was short, certainly probably less than a third of the whole cardiac cycle. And there you can also see the tricuspid regurgitation. And these to us suggest that there was some diastolic dysfunction as well as systolic dysfunction. There was a bit more of the tricuspid insufficiency, and I think this was just to show there was antegrade flow through the pulmonary valve. And certainly the duct did not look obstructed. So pulmonary outflows here, the right ventricle tricuspid regurgitation, you can see there. And so there wasn't evidence of ductal constriction. There wasn't evidence that the RV was so sick that it wasn't ejecting and opening the pulmonary valve. And there wasn't pulmonary insufficiency. They're just interesting findings. The LV, though, wasn't 100% normal at 28 weeks. This was more of what I would see at 12 weeks, where the E and A wave ratio is probably that E wave is half that of the A wave, which is more typical of a very early gestation. But the IVC flow was normal. The ductus venosus flow was still normal. And umbilical arterial Dopplers, I think, were still within normal limits. So we said there wasn't structural heart disease other than maybe a mildly dysplastic tricuspid valve, dilated RV with moderate systolic, mild diastolic dysfunction, Despite which, interestingly, the Tay indices of the RV were not terrible. Maybe because there wasn't as much diastolic pathology going on, but moderate TR, abnormal RV filling, normal IVC flow, ductus venosus and umbilical vein flow, so no pulsations, normal to borderline global LV dysfunction. The Tay there was a little bit elevated, and normal it should be about 0.4 or sometimes less. There was no high drops, and our cardiovascular profile score again was about 8 at this stage. We took 1 away for myocardiomegaly and 1 away for RV dysfunction and TR. When we counseled the family, we said we think this is myocardial disease. It's kind of subtle though, and we didn't know what was exactly going on. Was this a cardiomyopathy? Was it myocarditis? And it was involving the RV more so than the LV. At least when it's more univentricular and there's another ventricle that's functioning better, we've often seen that they haven't done as poorly prenatally, but they still can get sick after. And there was TR. There's potential for progression, for sure, including dysfunction and evolution of more biventricular dysfunction, even the development of fetal hydrops, which really prompted frequent surveillance. And in fact, we see these moms as we get closer to a viability. We're going to see these moms on a every week to 2 weeks sort of frequency. We aim for a 39 and then also work with our perinatal colleagues to look at other surveillance strategies, including I think NSTs are very helpful in understanding what the baby's tolerating. Aim for 39 to 40 week vaginal delivery at a high-risk hospital at this point, and then monitoring on the NICU with early postnatal evaluation by pediatric cardiology, and that would be within probably several hours. But it was unclear what this would look like long term. We, A, didn't have an etiology, and B, it was still relatively early, certainly from a fetal perspective. We recommended an MFM assessment, which was done. There was no other extracardiac pathology, and baby was reasonably well grown. Genetic counseling and testing had been underway, and then infection workup, including a torch screen, because we said, could this be a myocarditis? With the history and I'll tell you the mom's history, we had to really dig it out, but torch screen, other etiologies. We did things like enterorhino, looking for any other potential kind of virally mediated myocarditis, because it might help you think about treatment. And maternal autoantibodies we will routinely do in an unknown case of myocardial disease, especially if there's kind of a picture of fibrosis, but even in the absence, maternal and paternal ECGs and echoes are routinely offered, as well as siblings, if there are siblings, and in this case there was. We did initiate digoxin. That was our recommendation, which we do when there's systolic dysfunction. And if there's evidence of infection, we'd consider IVIG or maternal autoantibodies, steroids and IVIG. And then we couldn't exclude arrhythmia, so we sent her home with a Doppler device, and that was negative. She never had anything that suggested arrhythmia in that period of kind of trying to figure out what this was. Turned out her viral screen came back positive, and while she had a negative history when we initially encountered her nasal swab suggested she was ERV positive. She was not rubella immune, interestingly enough, and she was CMV DNA positive, but had a low viral load, and they thought this was likely reactivation. When we re-explored her history, in fact, just a couple of weeks prior, she had had bad diarrhea while visiting family in the Philippines. And then we wondered about the possibility of a viral gastroenteritis as part of this whole picture. And maybe that was contributing to what was happening with the baby. Parental and sibling ECGs and echoes were completed, and they were all normal. And then we certainly had a genetic consult. There was no relevant family history. The amniocentesis at this point was declined. She did talk about the possibility of late gestation testing, but eventually just had testing after birth. So we started DIG, and we usually do it as an outpatient, 500 mics twice daily for 4 doses, and then switch to 250 and get a level to know that our levels are within a therapeutic range. With possible myocarditis and a recent infection, in fact, we gave her IVIG. We didn't really have much else to offer, and we thought, if we could change the course of this, if it's not too late, it would be worthwhile. It didn't really do anything. And then we did very close ongoing fetal surveillance from the diagnosis. We held a maternal multidisciplinary meeting we do with our obstetricians or maternal fetal medicine folks, our neonatologists, fetal cardiology, our geneticists are often or potentially could be involved in those, and anyone else we think, including potentially even heart function colleagues if they're more complex patients. This one was hard to know because we weren't sure what was going to happen. She was planned for a repeat C-section at 39 weeks, and for the moment, because there wasn't evidence of a progressive decline in function, that she would be evaluated at the mom's hospital, where we have one of the highest acuity neonatal units and cardiologists on site. Her last echo showed, I think, that the LV was starting to look not as good, but there wasn't high drops, and still we didn't have big, huge changes in a lot of the venous Dopplers. A little bit of increased A wave reversal in the IVC, a little bit of longer duration of that A wave. And then the LV inflow was looking a bit more uniphasic, and the Tay index at that point was not normal, 0.8. Shortening fraction of the LV was 25%, so mildly reduced. We still said that RV was still more significantly affected. As you can see, we had uniphasic short duration inflows, shortening fraction of about 13%, and a Tay that had gone up to 1.15. So global biventricular dysfunction, no high drops. Baby's output wasn't terrible. There were still normal ductus and venosus and UV flows. And the cardiovascular profile score at that point, we thought was somewhere between 6 and 7, taking off 1 for the cardiomegaly, which was much worse, 1 to 2 for greater biventricular dysfunction. And that would potentially predict worse outcome. So this little one was born at 39 weeks with outgrowths of 5 and 9 at 1 and 5 minutes. Birth weight was 3.2 kilograms. Needed CPAP briefly and then didn't require any support, was transferred to the neonatal ICU and looked actually quite good. Baby was, in fact, asymptomatic in the first few days. And the initial echo I'm going to show you showed kind of biventricular dysfunction that wasn't great. And in fact, we were surprised the LV looked worse, we thought, than what it did prenatally. And maybe not surprised because we've suddenly taken away the placenta and the low resistance unit, so that maybe the left heart's now acutely facing higher afterloads. And we got a bit worried and said, nope, we want to transfer this little one over to our cardiac center in case this baby falls apart. And that's what occurred. So we transferred her over within that couple of days. There was definitely evidence of worsening LV function. I'll show you one more picture. This is, again, a very subtle case. Baby was started on all the anticonjunctives and support, as you would expect, as well as hypercaloric feeds. Cardiomyopathy workup was underway. Genetic testing was normal panel. Cardiomyopathy panel showed just a variant of unknown significance with a de novo CHD2 mutation. And then this baby was discharged in actually reasonable shape at 7 weeks with a diagnosis of idiopathic dilated cardiomyopathy, possibly post-infectious. And just to show you that LV really within weeks was blowing out with very, very low systolic function. The good news is, we were treating this baby and supporting this baby all along. And had it not been picked up, maybe this baby would have presented an extremis with us because this baby wasn't so terribly sick early on. She did have several readmissions and requiring NG feeds with failure to thrive. Was initiated on beta blocker, was on DIG, low molecular weight heparin, and other supports. By 5 months, in fact, was in decompensated heart failure, requiring ECMO and bridge to a Berlin heart LVAD, and ultimately underwent heart transplantation at 6 months. She's now at 7 years, has autism spectrum and neurodevelopmental delay, but is making progress. So with that, I'm going to stop sharing and open it up for questions. And I'm just going to have a look at the Q&A and pull my questions. If any of you have questions on the panel as well, please feel free to ask. Luke, so here we have 2 cases that we've offered DIG. Maybe you can talk a little bit more about our experience with its use.
Yeah, so I think, as you said, wherever there's systolic dysfunction, there may be a role for digoxin. So many of the dilated cardiomyopathies will fit into that that sphere. And I think we've also used it in other things like high output cardiac failure. We've occasionally thought there might be a role, even in things like Epstein's anomaly. We have sometimes thought there might be a role for it, and obviously it has some antiarrhythmic effects as well. So there may be a role in a whole range of cases. There's a little bit of data to suggest that that it may have benefit, and we have serially measured cardiac outputs in some of these cases, and in some cases it seems to show that there is a sort of improvement in cardiac output when we've started DIGE, although it's fairly anecdotal.
I've seen a couple, and again, as mentioned, this is also quite anecdotal. But I've seen a couple actually not necessarily have obvious improvements of systolic function, but actually, or I'm hoping that you can still not sure who I'm picking up here. But
I think you started screen sharing.
yeah, that wasn't me. Unfortunately. I've also seen it actually no change in heart rate, but result in improved filling, improvements in systemic venous Dopplers, which makes me think it may have also a role in diastolic function, which is kind of interesting and not really well tested and certainly worthy of further investigation. If that were the case, it might be something that makes sense for some of the worst end of the spectrum, where if they have diastolic pathology, they have a very high risk, as we're going to show in the fourth case. There was a question, one that may be helpful. There was a question about what was the association with the neurodevelopmental delay in autism. And I actually had wondered about the genetic workup and what specifically had been done, because it almost seemed like there was a cardiomyopathy panel assessment, but not necessarily WES. And was curious about that, because maybe the WES would have been helpful in picking up something else that was more global.
Maybe I can weigh in there
Okay.
as I'm still following her. So first of all, fortunately, that has dramatically improved. So she did definitely have signs of autism spectrum disorder as like a 2-3-year-old and was diagnosed accordingly. But in the recent 2 years, she has pretty much normalized in terms of her behavior, social interaction, and everything. And from a neurodevelopmental spectrum, she has also caught up to pretty much close to normal now. Having said that, we do see a lot of our cardiomyopathy patients having autism spectrum disorder, having neurocognitive delays. We know from our own study at age 4.5 years old with neurocognitive outcomes that particularly congenital heart disease patients have worse outcomes overall, but that there is a broad range. And the autism pops up for sure in regards to the association with cardiomyopathy. Sometimes it is something overt, like it is a mitochondriopathy or something that affects the brain primarily as well. Oftentimes it's not. And as you say, I mean, whole exome may be helpful or may not be, because oftentimes it's probably things that we just don't know, or it's a combination of things that may result. She had this CHD2 variant of unknown significance, which I don't think she fulfills the other criteria for the associated neurocognitive disorder. So yeah, I can't comment in her specific case, but fortunately she's improved dramatically.
That's terrific.
I have a question.
Yes.
I have a question for
Sure,
you.
Rima, thank you.
I just want first to apologize for not coming. At the beginning, we had an emergency, a twin pregnancy, and one was not doing well, IVF, and I had to talk to the parents and I had to be involved. I'm really sorry, but I knew that Alicia would take over and do the best of it. Now, I have a question for the digoxin now. That Huta was using it a long time ago. And he always said about the score, the correlation between the cardiovascular profile score and digoxin. And not a lot of people were into digoxin, into heart failure. So now, and I think he also noticed or said about improvement of systolic and diastolic function, and you are hinting towards that. So did the score improve with digoxin? For my experience, it improves by 1 when I give it digoxin for any reasons that we give in heart failure. Probably whether morphologically abnormal or did the score improve with digoxin or did not?
Generally not dramatically, but I think we're also looking for more subtle changes that may be enough to get the baby squeaking through without developing high drops. And it definitely warrants more investigation. And I think that's one of the questions for the Fetal Heart Society cardiomyopathy study, where we're looking at those that were treated with DIG, and we'll have some data there. I think it's also looking at the other cases that Luke had mentioned that we use it for. Yeah, there's one really decent paper out there that was on looking at changes in cardiovascular profile score that Bettina Cuneo had done with Jim Huda. But
many years back,
since they're the odd, really rare isolated case report, so I think it warrants further. It's certainly gaining favor, I think, among the heart function crowd, and Simon can weigh in on that. So we're seeing it more and more used in our postnatal cardiomyopathy patients. Michael, I noticed though that you have your hands up. Maybe is that, Rima, does that answer your question?
No, I have one more thing regarding the score and the dose. What 500 twice a day, and then you go to 250, based on what and the levels. And I know that the MFMs in our country are against the use of digoxin. They say there's no evidence that it works. So how do you overcome this in your country? You have your practice. And number two, on which basis do you go, by levels or doses?
By levels. So we have found that generally that approach gets us levels that are within therapeutic, which is somewhere between 0.5 and 1.5. I like it around 1.0, and
Yeah,
depending
0.8 to
on
1. Yeah, he used to say 0.8 to 1. That was
exactly. So that's what we aim for. And the good news is that approach with that loading and that amount tends to get us there. Sometimes in the third trimester, they need a little bit more, but we'll check the levels, once every few weeks kind of thing, just to make sure that they stay within. The cardiovascular profile scores we're looking at, but again, sometimes they're more subtle than those big categories of what you're going to, -1 or add back 1 are going to tell you. But we figure if it gets them through and gets them farther to closer to term, then that's good. But like I said, there's a need for more data for sure.
and then you do ECG for the moms before we start digoxin, right?
Oh, ECG, we do electrolytes, we do the usual stuff. The other is, I will tell you that we have had cases of maternal autoimmune mediated cardiomyopathy where there has been improvement, including resolution of high drops, and have had cases of critical S where there's been a little improvement in systolic function of the LV, a case with high drops where the high drops result as well. So, I think that there's room for it. It may not be that every cardiomyopathy
It will not hurt. It will not hurt, right? It will not hurt.
Totally. And that generally has been, most of the time, it's been pretty accepted by the family. So Michael, sorry, one more question and then we got to keep moving.
Sorry, this is a very small point, but I think it's important. And it just speaks to the ethics of how we talk about outcomes like autism or developmental differences. I think for this kid, the way we should frame it is it's very fortunate that this child is thriving, whether they have autism or they don't have autism, whether they have developmental differences or not have developmental differences. Autism is a possible outcome. It's not an adverse outcome, if that makes sense. And we try and talk about outcomes, framing it from a way that families understand the meaning of it in the context of what their child's life is like, what their childhood is like, not just as a diagnosis. So thanks.
Lisa, I don't know if you have a minute for me, because I think there were questions in the chat. And I just would like to clarify that, this gene CDH2 has been associated with 3 phenotypes, that being arrhythmogenic right ventricular cardiomyopathy, dilated cardiomyopathy, and a syndromic presentation with agenesis of the corpus callosum, cardiac, ocular, and genital findings. So the evidence from our standpoint for the dilated cardiomyopathy and arrhythmogenic right ventricular cardiomyopathy is limited at the moment. This family had a panel, and when you order a panel, it is not surprising that you will get a variant of unknown significance, which is much harder to interpret when it is a missense variant, as it was in this family. However, I can tell you that lately we got a referral on this family again, because the father has a cardiac phenotype. So we will reevaluate the family and will reconsider reanalysis perhaps after a number of years it's important to do reanalysis as more evidence is accumulated in the field.
Thank you, Oana. I apologize. We need to keep moving. We have 2 more cases, and we're going to have to keep this discussions a little bit shorter. And happy to be answering questions. I wonder if Shilpa can share her screen. And I'm not sure that you're at the beginning of your talk. Okay, take it away. Oops, we are missing your talk.
Okay.
Can you share your screen?
Yeah, just give me 1 second. Can you see it now?
There we go. Now if you can put it into, yeah, perfect. Thanks.
All right. So I will be presenting a case of hypertrophic cardiomyopathy. Based on the 2 cases that we saw, they can be giving you subtle clues and they can quickly progress as well. So that's what this case highlights. So we had a case of a 27-year lady who is gravida 2 para 1, was referred because of the increased nuchal thickness, measuring 3.2 millimeters. And she also had a high-risk first trimester screen for trisomy 21. So in terms of the family history, there was no history of congenital heart defect. Previous pregnancy was uneventful. So she came to us at 14 weeks of gestation, and her echo at 14 weeks was essentially mostly normal. So she had structurally normal heart, systolic ventricular function was normal. There was no significant AV wall regurgitation. Inflow Dopplers were normal. The only abnormality that we noted was there was significant AV reversal in the ductus venosus Doppler. As we heard earlier, that abnormal ductus venosus Doppler, particularly when you have some genetic issues, can be difficult to tease out whether this is a cardiac problem versus placental or fetal problem. But keeping that in mind, we followed her up. Sorry, I'll first show you the first echo at the 14 weeks of gestation. So this is a 4-chamber view where we're seeing right ventricle, left ventricle, so the balanced ventricles, and the ventricular contractility looks normal. And this was a short axis view of the ventricles, which again, we can see that this is the left ventricle at the bottom and right ventricle on top. Both of them look fairly normal with a good systolic contractility. Then, as I said, the only abnormality we noted at this stage was abnormal reversed A waves in the ductus venosus. The IVC Doppler was normal. The right and left inflow Dopplers were normal for the gestational age. So we can see A and A wave ratio was preserved and the diastolic filling time was preserved as well. Then we followed her up at 18 weeks of gestation and we were surprised to see this. As we can see again, this is the 4-chamber view of the heart. And we can see the right ventricle at the top and the left ventricle at the bottom. And we can see the right ventricular free wall looks thickened, and so does the interventricular septum. The systolic contractility is maintained. And then we go to the short axis view of the ventricles, we see again the interventricular septum looks hypertrophied and the right ventricular free wall looks hypertrophied too. So as I said, both the ventricles looked hypertrophied. Systolic function was normal. There was no significant AV wall regurgitation. The ductus venosus Doppler continued to be abnormal, and we also noted that the IVC Doppler now had become abnormal. So we saw this quite prominent reversed A waves reaching the velocity of around 32 centimeters per second, which was a new abnormality. The inflow Dopplers continued to be normal. Another abnormal finding that we noted was there was intermittent absent end diastolic flow in the umbilical artery Doppler. So as we saw earlier, the cardiovascular profile score is a good indicator of assessing the fetus. And at this stage, we calculated cardiovascular profile score of 8 to 9 by 10. This was based upon the finding of the abnormal ductus venosus Doppler and the abnormal umbilical artery Doppler. So based on these findings, we sent her for the MFM scan, where the imaging revealed there was mild skin edema. The liver was subjectively mildly enlarged, and there was some hypoechoic and heterogeneous character of the liver. Another important finding they noted was there was discordance in the fetal biometry. So the abdominal circumference was on 87th centile, and head circumference and the femur length were below the expected percentiles. There was intermittent absent diastolic flow in the umbilical artery, and the pulsatility index in the umbilical artery was elevated. MCA Dopplers were normal. The ductus venosus Doppler was continued to be abnormal. Most importantly, there were no significant extracardiac abnormalities noted. And from fetal well-being standpoint, the AFI was normal and the umbilical venous Doppler was normal. Now, based on these findings, we explained to the family that the findings are consistent with the hypertrophic cardiomyopathy. Of course, at this stage, the etiology is unclear to us. We all understand the importance of noting good family history. So we revisited the family history, and it did not yield us any clues, diagnostic clues. As we saw in the previous cases, we sent these parents as well as the elder sibling for the cardiac screening for the echo and ECG. One cannot underestimate the importance of genetic counseling in this situation. So we referred this case to the genetics team and urged again to consider prenatal diagnostic testing. However, the family declined genetic testing as they were keen to continue the pregnancy and were not willing to accept the termination option. So given that they were continuing the pregnancy, we suggested the importance of need to continue close monitoring. We also explained the fetal risk factors like further worsening of hemodynamic performance of the heart, development of the heart drops, risk of arrhythmias in this situation, and also high risk of fetal demise. We also explained the risk that the baby might have to be delivered prematurely, and that would have significant impact on how we manage the baby. If the baby was to develop hydrops, there is also some theoretical risk of Mira syndrome to the mother, contributing to some morbidity to mother's well-being. As I said, we discussed the pregnancy management options, and family had decided to continue with the pregnancy. We all know that the prenatal therapeutic options for the fetal cardiomyopathies are quite limited, particularly in the cases of hypertrophic cardiomyopathies. The only options we have are treating arrhythmias in case they develop. So we explained this limitation to the family. We also discussed the postnatal management options and that it would be guided based upon the gestational age and the weight of the baby. The cause for the hypertrophic cardiomyopathy, importantly, genetic and extracardiac anomalies would be important to consider transplant candidacy. We also explained that although there have been advances in the ECLS and VAD technology in the transplant management, there are significant limitations when it comes to offering these options to the preterm and small babies. From an investigation standpoint, we ensured that there was no evidence of gestational diabetes. The renal function was normal. There was no renal pathology. The viral screen was negative. And as I said previously, that the parental ECGs, echo, and siblings ECG and echo were normal. So we essentially had no diagnostic clues, etiologic clues for this case. We continued to monitor her very closely, initially once a week and then bi-weekly. And over this period of few weeks, we noted that the biventricular hypertrophy was worsening. Around 23 weeks of gestation, we noted that there was development of new dynamic LVOT obstruction, the diastolic function further declined with the inflow Dopplers becoming monophasic. There was significant AVAV reversal in the pulmonary veins. We also noted that the umbilical venous Doppler had started to look more pulsatile now, which was a poor prognostic factor. And another development was development of hydrops. So the baby started to show skin edema, significant skin edema, and small pericardial effusion. So if we calculate cardiovascular profile score at this stage, it was as low as 3 to 4, which is quite a concern. Around 27 weeks of gestation, we noted that there was significant variability in the heart rate, and with the lower heart rates, there was relatively better filling of the heart. So we started to consider our options to control the heart rate, and beta blockers was one of our options to consider. By around 31 weeks, we started to note that there was significant moderate tricuspid regurgitation. There were frequent atrial ectopics, and the combined ventricular output had started to decline. At this stage, we admitted the lady and discussed the option of starting propranolol, given the fact that there was frequent atrial ectopy and risk of worsening arrhythmia. So we started her on propranolol, 20 milligrams 3 times a day. By 32 weeks of gestation, we had managed to control some heart rate, but the atrial ectopy continued. So we increased the propranolol to 30 milligrams thrice a day. By this time, we had reached a gestational age of 32 weeks. By this time, we generally organize multidisciplinary meeting to discuss the progress that we have made so far, or no progress we have made so far, and then also explore the parental expectations to guide what the perinatal course is going to look like. We also broached the point of involving a CIS team. However, the family was very keen to pursue the active intervention, so they declined to see the CIS team or the palliative care team. At this point, they had accepted an option of genetic testing. So late gestation genetic testing was offered to them, and the genetic team kindly organized expedited genetic testing to understand the etiology and the prognosis for this case. From delivery management point of view, we decided that it would be an elective cesarean section, considering the high risk of arrhythmia and significant fetal compromise. In terms of the delivery location, it was thought reasonable to deliver this baby in a high-risk maternity unit and then promptly transfer the baby to the cardiac surgical unit. Another important step that we took around this time was to involve heart functional transplant team proactively at around 33 weeks of gestation, who explained the similar poor prognostic factors, considering the early presentation and the very rapid progression. They emphasized the importance of genetic testing from transplant candidacy standpoint, and also explained that the VAD or ECMO would not be an option for a baby less than 2.5 kilos. Around 34 weeks of gestation, we got the genetic testing results back. There was no aneuploidy and the microarray was negative. However, we got a diagnosis of autosomal recessive form of LZTR1 related Noonan syndrome. I think Oana can go with this in more details, but this is a relatively rare genetic mutation that is seen in the Noonan syndrome. And based on this finding, we started considering trametinib as an option for the postnatal management. Around this time, baby also had some preference of ventricular tachycardia, so we continued the propranolol. Over the next 3 weeks, the baby remained relatively stable from cardiac standpoint, and in fact actually showed some improvement in terms of the ventricular ectopy and also improved polyhydramnios and skin edema. So the baby was electively delivered at 37 weeks of gestation. Because of the concerns about the poor interval growth. Baby came out relatively well with a birth weight of 2.36 kilos with Apgars of 7, 9, and 9. Baby developed some mild respiratory distress and was commenced on CPAP. Had some low blood pressures initially, which was managed with the fluid therapy. And then the baby was quickly transferred to the postnatal, to the cardiac unit. This is what the postnatal echo looked like, very similar to what the fetal echoes looked. So we can see there was significant biventricular hypertrophy, preserved systolic function. One thing that was missed on the fetal echo was moderate perimembranous VSD, which was relatively significant and had bidirectional shunt across it. This is what the short axis of the ventricles looked like, and we can see how significantly hypertrophied the ventricles looked. So we've rediscussed now that the baby was out and we had the genetic diagnosis, we rediscussed expectations and what the prognosis is going to look like based on the literature that we have. If the hypertrophic cardiomyopathy presented with the heart failure symptoms before 6 months of age and arrhythmia, the risk of mortality is as high as 60 to 70%. And this is what was explained to the family. As I said previously, based on the LZTR1 mutation, we discussed the option of starting trametinib, and the family agreed to trial that. So we started that around 3 weeks of gestation, or 3 weeks after the baby was born, once the concerns about sepsis were resolved. Did we see any effect from the trametinib? So in terms of effects, we saw that there was some improvement in the BNP. So the BNPs came down from 11,000 to around 3,000 range. However, this did not translate into the clinical improvement. So the echo did not change and the baby did not improve clinically. The baby had a very prolonged PCICU admission for almost 3.5 months' time. The course was punctuated by multiple multiple infections, respiratory infections, line-related infections. We tried to start the baby on the beta blockers, but there was concerns about the low blood pressures and long sinus pauses, so the baby didn't tolerate that very well. Baby was quite fluid overloaded and needed significant diuretic therapy, which later on took a toll on the renal function. So with all this, we discussed the case in our multidisciplinary meeting with the surgeons, and it was clearly stated that the baby would not be a candidate for ECPR or ECMO, considering the poor outcomes for transition from ECMO to WAD, given the baby was less than 3 kilos. If the baby was to reach weight of 3 kilos, then the baby can be considered for WAD and potential transplant candidacy can be revisited. So in preparation for transplant workup, the baby had cardiac MRI, which showed the significant biventricular hypertrophy. There was no late GAD enhancement, and there was mild fibrosis. The baby continued to have progressive LVOT obstruction, and there was significant worsening in the pulmonary hypertension. So with this, we discussed the case in a cardiosurgical conference, and it was thought reasonable to consider cardiac catheterization. And as we can see from the cardiac cath data, the pulmonary artery pressures were systemic range. The PVR was quite elevated, and unfortunately, there was no evidence of vasoreactivity. So this was disappointing. After the cath, the baby had significant cardiorespiratory decompensation and got reintubated and also needed significant cardiac support. So we explained poor outlook to the family, and particular concern was a pulmonary hypertension at this stage, but the family was still keen to pursue all the interventions possible. And hence it was thought reasonable to close the VSD, initiate the BIVAD support, go ahead with the lung biopsy, and start the pulmonary antihypertensives and reconsider catheterization in 3 to 6 months' time, depending on the clinical status. However, it was also agreed upon whether if the lung biopsy showed significant pathology that would preclude transplant candidacy, then in that case, it would mean withdrawal of support. If the baby showed clinical improvement, then in that case, the baby would be a transplant candidate. So the baby ultimately ended up getting BIVAD support and then was upgraded to the Berlin heart. There were significant issues because of the BIVAD suction events. There were significant hemodynamic instabilities, endothelial dysfunction. There was SVC syndrome because of significant hardware in a small baby. There were complications because of the coagulopathy, needed multiple re-explorations for cannula positioning and the bleeding. Pulmonary hypertension continued to be a significant problem. So when we started therapy for pulmonary hypertension, the baby was on nitric oxide but did not tolerate sildenafil, so we could not optimize the pulmonary hypertension management, and there was no improvement from pulmonary hypertension standpoint. The baby also ended up getting multiple other complications. As I said, needed significant diuretic support, developed renal dysfunction, chylothorax, multiple episodes of infection and seizures. So overall outlook was pretty bad. By this stage, the baby had reached an age of 6.5 months. So all this complex medical course so far was discussed with the family. It was reiterated that the pulmonary hypertension is a critical point, and we haven't made any progress from that standpoint. So assisting was re-engaged at this point, and the family ultimately redirected care, and the supports were withdrawn. So the baby demised after this. So the key management points from this case, I'd say.
I think, Shilpa, maybe we will stop here, have a very brief discussion, if that's okay, and then only because we have a little bit more to discuss. This is a good. Oh, you can leave up your key management points because that's certainly all the relevant things, but it is obviously an example of how challenging some of these babies can be and the uncertainty of their the evolution of their heart disease and how we're going to manage them, and just really telling us sort of the issues that can arise and sort of the complex decision making that is done with the families. There was one question that came up from the audience, why termination was even considered, and I think that was at the original diagnosis, I think at around 18 weeks. I know maybe Shilpa and Sue can weigh in on sort of why we would even provide that as an option.
Well, just from the maternal fetal medicine side, I know it probably differs depending on what country you practice in, but in Canada, the option of pregnancy termination is available to patients under 20 weeks for social reasons and under 24 weeks if there is a congenital anomaly or a genetic diagnosis that may impact the patient's life. And so, and different jurisdictions have different nuances around that. So we already knew at 18 weeks that there was a significant cardiac issue. And the other thing from the MFM side is if there was already mild subcutaneous edema, my concern about the liver was large, and that's why the AC was higher in size than the femur length and the head. This mother also had a risk for Mirror syndrome. So I think both for fetal indications and maternal indications, that's an option available to our patients.
And then Shilpa, from a pure cardiac standpoint, what do you think? And I agree, Sue. I mean, it is what, our practice is, but from a pure cardiac standpoint.
Yeah. So as I said previously, that by 18 weeks, we had already started seeing quite significant ventricular hypertrophy as well as diastolic dysfunction and evolving hydrops in terms of skin edema. As I mentioned, if you have hypertrophic cardiomyopathy presenting early in the fetal life, and there were subtle indications that there could be some genetic issue based on the nuchal translucency abnormal FTS. This indicated overall poor prognosis, and hence that was discussed as an option.
And the uncertainty and concern about evolution with, yeah, absolutely. Rima.
Beautiful case, but there's a point that I'd like to raise now here. We see a lot of hypertrophic cardiomyopathy, especially I practice in Saudi. We have GDM and all that. Now, when would you say this is a hypertrophic? Because Lisa, could this be transient part of the normal fetal life? Because I've seen quite a lot of little bit of hypertrophy, and the hemoglobin A1C is normal, and OGTT is normal. So how can you explain the hypertrophy, biventricular hypertrophy, and asymmetrical septal hypertrophy on those fetuses? That goes to the panel, because I think there is a reason in a fetal life. And number two, to you, Shilpa, this is a very confusing case. I mean, what happened postnatally? A lot of problem. Is it the Noonan or is it the heart, the edema and all that? And number three, why you chose propranolol? There was, I mean, is this a safe one? And other thing that you wanted to use, like three questions. I know Lisa is going to kill me. But I think maybe a lot of people will have the same way of thinking. Thank you.
Yeah, I think from the first question, that's a good question. And certainly when you're in the mid-trimester, the first thing we're thinking of is a gestational diabetic. They usually don't have those venous Doppler changes. That is not a typical feature of some of the worst of the hypertrophic cardiomyopathy pictures of an infant of a diabetic. You just don't see that kind of dramatic diastolic pathology. And we were seeing it at 18 weeks. The other thing, interestingly enough, I will tell you the Noonans that I've seen, they've had kind of that, ballerina slipper appearance to the LV. You know it. Just as soon as you see it, that funny shape of the LV is just a classic finding. And I have seen it every time in every one of the Noonans, including this baby. So, have your little spidey senses up, especially if it's in the earlier mid-trimester. You don't usually see hypertrophic cardiomyopathy. It should be something that you start thinking about. Could this possibly be an actual myocardial process? may end up being a part of a bigger process in the baby. And that's going to be what our job is, to be 100% sure that's not the case, you know?
Could be pumpy. It could be pumpy disease.
Yeah. Sure. Absolutely. And there may be treatment for that, right? Simon.
Yeah, I can weigh in on a lot of your other questions probably. So with the hypertrophic cardiomyopathies in Noonan's, you're absolutely right. Often the limiting factor is not the heart itself, but it is the lymphatic abnormalities that they have and that are not responsive, not improving, independent of how the heart function responds. In this case, particularly, and sorry, so propranolol would always be the first line treatment for hypertrophic obstructive cardiomyopathy. So if you have outflow gradient, that would be the first line, and then adding disopyramide, independent of the origin. The
Antenatally?
not
Antenatally?
antenatally, postnatally.
Yeah, I know antenatally it's not perfect, but it is the one beta blocker that people have used. It's just that you don't get perfect coverage, and you just have to recognize not all of it's going to get to baby.
And you were playing with
And
the doses, right? Up and down.
totally. So we'll go up on higher, but then sometimes mom's getting the side effects. So from a fetal standpoint, it's not a perfect drug, but it's sometimes the only drug we have, say, or the one drug we'll turn to for something
Safest,
like
yeah.
VTAC. Yeah.
And then the
And safest.
trametinib is specific to certain variants of Noonan's. It typically does not apply to PTPN11, which makes about 70% of the Noonan's, which is unfortunate. And we individually check with the people that have most experience if they think it's reasonable in those patients. There have also been attempts with sirolimus that haven't been proven to be of use, really. But the trametinib in some cases works dramatically, like really completely normalizing function, usually within 3 months. And usually, if they don't respond by 3 months, then they don't respond. In this case, the very high pulmonary pressures with no responsiveness was a contraindication to transplant. From my perspective, actually was also contraindication to even place the ventricular assist devices, but there was some hope to improve things. But usually, if you have non-responsive PVRI of higher than 7, we wouldn't list the child for transplantation. And that was independent of the cardiac situation. That's why I was never very hopeful that placing a VAD would improve anything there in the longer term. And it was already at the 3 months mark where it was pretty obvious that she would not be one of the responders to trametinib therapy. Within the trametinib experience, it's about 30% of them that do not respond, and they typically pass away within the first year.
So Noonans have a poor prognosis, antenatally diagnosed? Is this a common thing? To say to counsel saying poor prognosis? I'm not sure of that though.
No, I think only in a situation like this. I mean, we have lots and lots of Noonan's patients that have very mild phenotypes. They often also have a pulmonary valve stenosis that sometimes can be ballooned and fixed. They often have this pattern of a septal asymmetric hypertrophy that's not obstructive and just need monitoring or beta blocker therapy. So the majority of Noonan's, which is a very common syndrome, will not be in such a high risk situation. But yes, the hypertrophic cardiomyopathies that die within the first year are almost always Noonan's patients.
And there may be some presentation bias with the fetal diagnosis and screening, right? I mean, if there's big time cardiac pathology, it's an easy thing to find. Or if there's high drops, you're looking for, if there's agenesis of the ductus venosus. So you may be picking up a more severe end just by fact of what we're scared. So if you guys don't mind, we'll move to the fourth case because it's kind of an interesting one as well. And then hopefully we'll be able to get through the findings of the fetal cardiomyopathy study, which I think people will find really helpful in their practice. So we call this one subtle but deadly.
Yeah, so I'll try to race through this just to give some time for the presentation of the results. So this is the case of G2P0 presented at 19 weeks with mild left heart dilation on anatomy scan, seen at a bit of a delay actually at 24 weeks by maternal fetal medicine and found to be large for gestational age. Possible agenesis of the ductus venosus was their thoughts, and these are the pictures that we then saw when we did a fetal echo. So I think it's fair to say that even with the benefit of hindsight, I wouldn't have said much about this. So the systolic function looks relatively normal. The cardiac size looks relatively normal. When we look at the flow, there's not really any tricuspid or mitral regurgitation, and anatomically things all seem pretty fine. And then in short axis, again, you can see that the left ventricle on the top there looks pretty normal in systolic function, as does the right. So first glance, everything looks okay. We go on to look at the diastology though, and we find that there's some subtle findings of RV filling, which is fused and perhaps a little bit short. But when you come to the ductus venosus, there's really marked flow reversal, A-wave flow reversal in the ductus venosus. The LV filling also is very abnormal with very short uniphasic filling pattern, and even the pulmonary veins, we see this sort of flow reversal, and you shouldn't really see any flow reversal or very little in the pulmonary vein. So this is a very sort of unusual finding in the absence of, something like a hyperplastic left heart syndrome with a restrictive septum or something like that. And the umbilical vein was also abnormal. So this was all very concerning. So we thought that there was probably a restrictive cardiomyopathy given the absence of sort of other placental pathology or things to explain these findings. And you really wouldn't see pulmonary vein Dopplers like that in that setting anyway. There was evidence of high biventricular filling and central venous pressures. And there was obviously a risk for hydrops and fetal demise. Genetic counseling, again, recommended testing, which was declined. There was no family history of cardiomyopathies. The patient was seen by maternal fetal medicine as typical. Termination was declined. The usual investigations were sent. ECGs were recommended but not initially completed. And mum did have an echo, which was normal, but the paternal echo was not done. And then in terms of progression, we saw the development of hydrops. So there was, in this picture, you can see that there's a significant pleural effusion shown. And we worried that this represented evolution and was associated with poor prognosis, the usual discussion we have about the gestation and weight you would need to be a candidate for a transplant or a VAD. Again, palliative care or termination was offered, and the patient opted for a termination of pregnancy. An autopsy was performed, which showed hydrops without cardiomegaly and no infiltrative or myocardial process, so no evidence of myocarditis, and the RAD, microrace, and cardiomyopathy panel were all normal. And then the patient came back with a second pregnancy 2 years later, and had a fetal echo at 14 weeks, and then left the country for a period and had an obstetric ultrasound outside of Canada, which unfortunately showed some ascites. An amnio was performed out of country and was reported as normal, and she returned to us at 22 weeks. And again, you can see here the pulmonary vein Doppler showed very marked A-wave reversal. The IVC shows very marked A-wave reversal, and the DV also does. So similar findings to the first pregnancy. We were worried it was the same thing. We followed up, and at 23 weeks, the patient started to develop some ventricular ectopy. You can see here the sort of irregularity and variability in the A waves. This nicely shows like a ventricular trace, which is the sort of less bright trace, and then the A wave reversal, and you can see that the ventricular rate is faster. So, and likewise on the M mode, you can see that there's a ventricular rate that's independent of the atrial rate and at a faster rate, suggesting the likelihood of ventricular tachycardia or jet. So EP was consulted. We initially started sotalol, increased it. It didn't really help, and then we switched to propranolol, which, as we've just discussed, is what we would more often use for ventricular tachycardia. Eventually got parental ECGs, and interestingly, although the maternal ECG was normal, the paternal ECG showed a incomplete right bundle, borderline PR, and possible Brugada pattern in V1. Whole exome sequencing was done, which showed a likely pathogenic SCN5A. So you'll remember this can be associated with both long QT and Brugada syndrome more typically, but also cardiomyopathies, and that was found in the paternal, and there was a variant of unknown significance, but one that has been associated with dilated cardiomyopathy and non-compaction and depolarization polarization abnormalities. So unfortunately, this second pregnancy also resulted in progressive hydrops, and we were unable to really control the tachyarrhythmia, and the patient had a late termination of pregnancy at 28 weeks with really, futility of continuing. She then presented again for a third pregnancy, and we screened. 13, 17, 20-week scans seemed to be normal. RAD, so the coronary villus sampling was done. The RAD was normal. The SCN5A mutation was positive. And again, at 24 weeks, we saw sort of later onset of similar findings from the first two pregnancies mentioned, and the patient underwent a termination at 26 weeks. So, and mitochondrial sequencing was additionally added, and no abnormalities were found. So that's it. So I just raced through that, sorry, but in the interest of time, and I think probably it'd be of most interest for Oana to comment on these cases.
Yeah, thank you, Luke. Yeah, this was a very dramatic and complicated case, and it's not actually another one that's not finalized in a way, because our results are not very clear to explain what happened. So the SCN5A, obviously very well-known cause for these kind of conditions, is coming from the father. The father had a completely normal phenotype. There was the PRDM16 variant that was inherited from the mother, but then there was another potassium channel gene that was also inherited from the father. And these obviously raised a lot of hypotheses, because all these genes are involved in the etiology of the conditions we are discussing today. However, we do not have enough evidence, because the latter two variants are variants of unknown significance. And this is not unusual in genetics, and this is where we need to intervene and perhaps think beyond the clinic. And this was the case here. So these variants, at least the potassium channel variant, was taken into the research area. There is a lot of evidence in the literature for patients who have more than one channel genes involved in their etiology, be that two variants in potassium channel, or now we have further evidence to see that there is a transcriptional pathway shared between the subunits of the sodium and the potassium channel. So this definitely could be a hypothesis here. Now, clamp patch experiments so far on the potassium channel variant have been normal. However, that is not the entire story, and we are planning to continue the studies. Very complicated from every point of view.
Yeah, I mean, I have only seen one other case in 35 years of a restrictive cardiomyopathy. I think they can be very subtle, and they're probably missed. And certainly any baby with any degree of hydrop should be evaluated. This was such a subtle finding, but those venous Dopplers were not. And again, it speaks to the importance of finding it, because then ultimately this is important for this family and the counseling, the initial counseling, and also risk of future pregnancies being affected. This was a
So
pretty
any case with
traumatic.
hydrops at this moment in time will be definitely having whole exome sequencing as a trio. Yeah.
Any other comments from the team, Rima? Sorry.
I think you're muted, Rima.
Thank you. It's a very interesting case. Yeah, to come to diagnosis of constrictive or restrictive cardiomyopathy is not an easy thing antenatally, correct?
Yeah.
So how
agreed.
how did you think of it? Is it because of, I mean, we see a lot of non-immune hydrops, and the MFMs hardly refer them because they think, oh my God, if it's 20 weeks, he's not going to make it till 40. Now, from this, I've learned a lesson is that you do WES for any hydrops. Is this correct? Is this a message to take home? Number
Yes.
two, how did you think of its constrictive or restrictive? Is it because of the abnormal ductus venosus, or how did you come to the diagnosis? Because really, you didn't see this Mickey Mouse or whatever that we see postnatally, or thickening of the pericardium. I don't know if, as Lisa said, it's not an easy diagnosis to make, right?
It's not
And
easy. I think
postnatally, there was a autopsy done for the first case, right? There was autopsy. Did it say anything about constrictive, restrictive, whatever it is? Oh.
No, it just said there wasn't infiltrative processes or signs of myocarditis. So yeah, so I think it is a difficult diagnosis, and I remember this first case because I did the echo when I was a fellow, and Lisa reported it, and it was sent to us with a query absence of the DV, and I think I could see that there was a ductus venosus, but there was just really marked A-wave reversal, and sometimes you see that for other reasons, of course. There didn't seem to be a lot of evidence of those other reasons, like placental pathology, for example, or growth retardation in this fetus. And then I think the real clue for us was that it was on both sides of the heart. So the pulmonary vein Dopplers also showed really marked A-wave reversal, and we really just don't see that very often. Even when you see a fetus that's in trouble from non-cardiac pathology, you don't usually see abnormalities of the pulmonary veins. So I think a real clue for me was that it was on both sides of the heart with A-wave reversal.
I
So
think it's just having also a low threshold to follow them, to see them. Get, from the obstetrical standpoint, get fetal cardiology just to have a look and to follow them, because some of these things will evolve and become more obvious. And I mean, for this case, it was just the most dramatic venous Dopplers I had seen in a very long time, and to have nothing else on this. And it made me think, oh yeah, I'm sure these are missed all the time. Like, and then the babies go on to die because this baby
venous
died within.
Venous Dopplers where exactly? Pulmonary veins only, or all
So
venous
what we do
Dopplers?
All of
inflows.
them.
Inflows can be early abnormal, as we've shown in the other cases. Pulmonary venous Dopplers, IVC flow, ductus venosus, umbilical venous flow. They were all grossly abnormal in all three of these babies when they were evolving
So they
disease.
were showing increased central venous pressure, right? The A-wave reversal, whatever. It could be for many reasons. I think it's a sad story, very sad story.
But not for many reasons, because when it's not the heart as a primary, either it's something that's compressing the heart, which you're going to see. You don't get you don't get inflow Doppler pathology like we
Okay.
saw. So, it's starting from the heart. In this case, it was already there all the way throughout. But for a lot of cardiomyopathies, they start in the heart. You find some subtle changes. And I showed you that with the second one. And yet that was going to predict ultimately this baby developing very bad cardiomyopathy. You're looking at subtle changes in the heart. And then it slowly progresses through the venous Dopplers, right? So be looking initially for those inflows and the pulmonary vein flows, and they may be very subtle early, but if you're seeing things that aren't right, bring them back. They're usually progressive.
And the PFO was what? From shunting right to left to right? What was it?
I think it was right to
I
left.
don't remember. Yeah.
And did we think of doing maternal hyperoxygenation tests in this case? Is it worth doing?
I don't know.
No,
I've
it's a
had anything.
biventricular disease.
Okay, it's not
Yeah.
lung.
I think if it's unilateral, you might think about something like that. But if it's bilateral disease, I don't know that it would really help you.
Agree.
Thank you.
So I thought in the last couple of minutes we'd just run through findings of a just fresh off the press fetal cardiomyopathy study done in collaboration with the whole of the Fetal Heart Society and published in Circ Heart Failure that I think will be very interesting and very helpful for those who are managing. Also bringing forward some questions still that are left to be answered. Certainly, we know that fetal cardiomyopathy is a rare cardiac diagnosis, and of most series, it's representing 2 to 4%. But importantly, it's the most common etiology of intrauterine death due to a fetal heart condition. We know that it carries a poor prognosis for the fetus with risk of hydrops and intrauterine fetal and neonatal demise, whether or not there's hydrops. And this has been reported in up to 60 to 80%. So very high risk lesion when we're seeing it. And it's part of why we talk about termination of pregnancy as well, thinking that this is a very high risk of progression. There's, as mentioned, risk of maternal morbidity and mortality due to Muir syndrome when the babies develop hydrops. But the literature was really quite sparse and represented mostly single center experience over decades, making it really a challenge for us to know how to counsel and ultimately manage with our current available expertise, including our heart function transplant folks, current genetics, et cetera, and having a more current update on this was really important. Our past studies without currently available genetic testing suggested actually the vast majority of cases were idiopathic. But we had a recent experience in looking at more recent genetic testing that we were finding a definitive genetic diagnosis in more patients than had been previously described. So we said, you know what, we need to do this. And Angela McBrien, my colleague and who runs our fetal and neonatal heart program here at the University of Alberta and the Stollery Children's Hospital, actually spearheaded this multi-center collaboration with the Fetal Heart Society. And as mentioned, this was literally just published last week, so you can find it online through Circ Heart Failure. So we were quite excited about this work. It was a multi-center study that had 3 aims. We were seeking to investigate genetic associations now with newer genetic testing, extracardiac structural anomalies in fetal cardiomyopathy, as well as genotype-phenotype correlations in this era of more advanced genetic testing. And I think there's more, as expressed by Oana, to be learned about these cases and some of the severe phenotypes to explore clinical outcomes in a contemporary era, including the contribution of genetic etiologies, extracardiac pathology, and also how we're doing with respect to the management, and to further refine echo-based hemodynamic predictors that are associated with worse or better clinical outcomes. Those that are in italics, we've already done. And that's what I'm going to present to you, but there's still work underway, and Shilpa's very much a part of that right now, reviewing all of the echoes to refine our understanding of the diagnoses. So this was a single-arm retrospective multicenter cohort study. It included cases of fetal cardiomyopathy encountered in participating institutions from January of 2017 to December of 2021, involving 25 North American centers. So not a very common diagnosis, of course, but an important one. We used, at this point, contributing institution definition of the cardiomyopathy subtype. We hadn't yet reviewed the echoes to kind of be more consistent in our definition, which Shilpa is doing now. Our inclusion criteria included those with cases of primary fetal cardiomyopathy where there was systolic or diastolic dysfunction, thought to be due to myocardial disease without an identifiable other disease. We did have a few with structural heart disease, but that was where the structural heart disease in and of itself didn't explain the degree of dysfunction. And for those of us in pediatric cardiology, you know that we're starting to encounter babies with structural heart disease and clear cardiomyopathy as well. And then those with fetal arrhythmia where the degree of dysfunction couldn't be explained by the arrhythmia. And then we excluded any of those with secondary myocardial disease caused by structural heart disease, arrhythmias, and non-cardiac pathology. So we had 143 moms with 148 affected pregnancies, 5 of which were in 2 affected pregnancies with recurrence. The median gestational age diagnosis was about 29 weeks. We've actually seen cases even in the late first trimester, so important to realize they can present earlier. Indications for fetal echo, you can see the most common were for a suspected fetal heart disease in half of these, which means our OB colleagues have to be out, and radiology colleagues need to be screening and thinking about looking at function. 18% family history and 11% presenting with fetal hydrops, and you can see some of the other indications. Interestingly enough, of the 29 with a family history, for what it was worth, most of them, 55%, or the majority, had one affected sibling. There was one that had more than one affected sibling. And then you can see about a fifth had paternal heart disease, about 14% had maternal cardiomyopathy, and then there were others that had remote family members that were affected. But I think these were the ones that were referred for family history. In fact, there were 11 others where we discovered another family member with us. So the fetus was, in fact, the index case for this family of having a cardiomyopathy diagnosis. I think that's actually really an important point. This is the breakdown based, again, on institutional reporting of what kind of subtype it was, with dilated being the most common, 40%, hypertrophic, 24%, non-compaction, 19%, and then you can see mixed, restrictive, very rare, and then not reported subtype, but we're looking at these echoes now. There were 21% of them or so had an extracardiac lesion, and you can see the most common were urogenital and cerebral. We threw in placental as an extracardiac, but really it's, structurally, these were some of the findings. They're important because they end up impacting outcome. 72% had genetic testing. I don't know exactly how many had higher level testing or the newer generation sequencing. And these reports were reviewed by a central geneticist. This was Dr. Calicirio Awana, who's on with us today. A definitive genetic diagnosis was made in 34% of those tested, and a variant of unknown significance in an additional 27%. And, we may learn more about these VUSs as we have more cases and we're potentially identifying that as an etiology. Of those tested, and sorry, I know you're a purist, and it's important to keep that in mind that we need to be careful. Of those tested, 43% had hypertrophic, 43% had a hypertrophic, 37% a non-compaction, and 27% dilated cardiomyopathy with phenotype. And of these, it's giving you an idea of the percentage of those with the different kinds had the genetic etiology. I apologize, that wasn't quite expressed exactly how I wanted it. Most common genetic diagnoses were MYH7 variants, which made up about 22%, and RASopathies, which made up about 16%. And then I've just listed some of the genetic diagnosis phenotypes. I won't go through all of these, but importantly, 70% of these diagnoses were made only through next generation sequencing. So really important, you're not going to catch these on microarrays and certainly not on karyotypes. So, this has to be considered, and it speaks to the comment made by or the question made by one of the earlier participants. So really important. These are just examples. This is a baby who had an HRAS gene mutation associated with Costello. Kind of looks a little non-compaction to me, but we consider that a hypertrophic cardiomyopathy going along with Costello. And then these were kind of interesting cases, just a couple of first generation cousins from a mom and then a father of the other pregnancy, both having a non-compaction appearance of their myocardium in a family that have known MYH7 with associated bicuspid aortic valve, and only one kitty was, I think, initially identified the grandfather, and then there are uncles and aunts and others that have it, and only one kitty has actual systolic dysfunction. So kind of an interesting finding. Fetal arrhythmias were present in up to 11%, about half and half at presentation and on follow-up. One of them was heart block, some level of heart block. Some we had included a couple of cases of maternal autoantibody-induced myocardial disease, so that makes sense. There was sinus bradycardia, and then some ectopy and much more rare ventricular tachycardia and ventricular ectopy. So just to give you some sense. Hydrops was present in 27% at presentation, in the larger proportion of them, 18%, and then on follow-up in 9 to 10%. And then importantly for counseling, Mirror syndrome in these hydropic fetuses was found in 3 or 7.5%. So in terms of presenting that as a risk and risk to mom's health, it's important. This is actually one with Noonan's who also had agenesis of ductus venosus, but in fact also had some venous Doppler changes as well as high output. So probably not a healthy combination. So outcomes of those 148, there was termination of pregnancy in about 7%. 70% of those had high drops, so that, these were very high-risk babies. And then of those that had fetal death, which made up 8% of the total cohort, 11 of the 12, in fact, had high drops, which was a major contributing factor, no doubt, with cardiovascular compromise. And that 11 cases represented 33% of those with high drops and pregnancy continuation. So once they have high drops, it's a very high risk. So we had 124 live births, or 84% of the total. And this is, again, with being more aggressive in the way we manage them as well. It's of note that those with palliative care from the outset were 11 or just about 9%, and 7 of those, in fact, were grossly hydropic, all with death that occurred largely really early after birth, within days after birth, sometimes within the first day. And then we ended up with 91% to 113 that were intention to treat. So of those, the primary outcome we looked at was how many were alive and at 1 year that had transplant-free survival at 1 year. And just we had 85 of those 113 with intention to treat, or 75%. And then of those, 16 or 19% had a cardiac transplant, and 69 or 81% had no cardiac transplants, some of whom are still waiting on the list. Death before a year, we had 28 cases or 25%, and with cardiac transplant, we had 2 demise after their transplant, and 25 or 89% demise without a transplant. So just to give you an idea of the way they were managed, cardiac transplant listing occurred in 21%, and of those that are transplanted, 67% are alive. Just a couple of them had passed, as mentioned. And then of those that have not been transplanted that are alive, there are 3 that were listed, and 3 transplanted, not transplanted, had demised as well. So it gives you a little bit of a breakdown. So what about mechanical support? We have now that, and folks are getting more aggressive. 11% had mechanical support of the cohort that were actively treated. And I just combined the ECMO, whether or not they went on to having a VAD, and the median age was 80, but we had some that were put on ECMO literally in the first day, as you can see with the range. For ventricular assist device, 71 days was the median days, and it gives you an idea. I think the earliest was at about 3 weeks or so, one of our patients that was bridged with ECMO to VAD, and this 3 of them, only 3 had ECMO without ventricular assist device. It's of note that there were some that went right just to VAD, and some of these discussions are already had even prenatally, just with respect to what we should be thinking about and how we should approach them. And then there was non-transplant VAD ECMO surgery that occurred in 12%, one of which was interestingly an anal hybrid procedure, which I wonder if the left ventricle was so blown out, if they then worked with the right ventricle and basically created a single ventricle kind of physiology. And all of these are alive following cardiac transplant. So kind of interesting. Just an example of a very bad one with biventricular systolic dysfunction, bad AV valve regurg, all the venous Doppler changes described, and kind of an evolving hydrops. This is a little one that had very low cardiac output that was delivered at nearly 37 weeks by suction in our cardiac OR. We were worried this baby would fall apart. Interestingly enough, and I think all of us, for a lot of these kids, there was a little bit of stability initially, and whether it's sort of their own adrenaline at delivery, it's not clear, but sometimes for a short bit, they're actually quite stable. And we've started to not really push for deliveries in our cardiac OR. This little one ultimately required a VAD within a few weeks and has ultimately undergone cardiac transplantation, has a known genetic mutation of CAMK2D. So kind of an interesting example, another example of a more severe case. So overall, of those with intention to treat, freedom from death or transplant was 61%, and you can get a sense for kind of how it stabilizes out after 6-7 months. For those with intention to treat with just freedom from death, including our transplanted kids, you can see again at about 5-6 months, you sort of get stabilization, but with attrition early. And then these are overall outcomes that included all of liveborns, including those with palliation. And just looking at subtypes, the dilated non-compactions were put together because as we're reviewing these cases, in fact, most of those described as dilated have a lot of non-compaction appearance. And we don't know quite how to describe this, and we're going to look at it in a bit more detail. It'll be a part of the next publication. But looking at hypertrophes versus this group, there wasn't a real big difference in our experience. And then finally, the highest risk factors when looking both with univariate analysis as well as multivariable analysis, highest risk factors was not necessarily the genetic diagnosis, but actually extracardiac pathology, and that's whether it's univariate or multivariate. Both of these came out as the highest, so this is extracardiac, and then the presence of hydrops at presentation versus no hydrops also, so at presentation. So an important one, not necessarily evolving hydrops late, which may speak to the fact that we're changing the outlook and trying to get these kids out or doing other things to try to optimize their cardiac function and keep them hemodynamically stable. So in summary, fetal cardiomyopathy represents clearly a diverse range of myocardial pathologies and etiologies. A definitive genetic diagnosis among those tested, at least in our experience, which was quite large, was at least 34% with MYH 7 variants in restopathies, representing nearly 40% of those with genetic testing and a diagnosis. Next generation sequencing is absolutely required for the majority, and we're talking 70% only had a diagnosis made when we did higher level genetic testing. And importantly, a fetal cardiomyopathy diagnosis may, through cascade testing, identify an affected or more than one affected family member and really push for cascade testing of other family members here. Most, 91% in total of our fetal cardiomyopathies with continued pregnancies did survive the neonatal period or did survive the gestational period and were born live born, but clearly there were some that chose palliative care for a number of reasons, both from a genetic, mitochondrial, metabolic, also just with respect to how severely affected they were. Overall survival among our pregnancy continuation cohort was 62%, and among live borns with intention to treat, our survival was 85%. With at least about a fifth having undergone cardiac transplantation. So just in terms of counseling families and sort of some of the expectation and kind of guarded prognosis, but better than we expected. Hydrops and non-cardiac pathology are key risk factors for worse outcomes. As mentioned, 7.5% of these moms ended up with whose babies had hydrops went on to develop Muir syndrome, which is a real risk for the moms and a reason that you need close surveillance with your obstetrical colleagues. And then newer strategies, including pharmacological therapies and mechanical support, as well as engagement. Really, the importance of this multidisciplinary team with expertise in fetal and neonatal cardiomyopathy, including all the players that you've met today and others, have likely been important to the improvements that we've seen now in total and transplant-free survival. So I think we still have a lot more to do. The future is central review of these echoes, getting a better sense of the phenotype-genotype correlation and phenotype-genotype outcomes. I think there's more data to be gathered here, and Shilpa is working on this now and trying to refine some of the predictors. And we're really keen to develop a prospective registry that allows us to do this genotype, phenotype, and identify cases and really provide better spectrum of what we're seeing for any given, for instance, genetic diagnosis. And finally, further evolution of pharmacologic and medical surgical strategies are really needed to optimize outcomes before and after birth. So with that, I want to thank you for your attention. I don't know if what we have for time for any additional questions. I apologize, we ran through this quite quickly.
Excellent, as usual. I think we should not leave you without questions, Lisa. This is an important study, very important study. I just have a quick question. And you mentioned it at the summary. Phenotype, genotype correlation. Do they have anything?
Yeah. So, I mean, what we need to know is when we're seeing this, what are we sort of what should we be thinking about with respect to testing? So I think it will be very helpful to see, I mean, some Noonans don't develop this myocardial disease and others do develop this. You know, it's helpful to have this data to better understand what are the manifestations of these specific genetic findings, right? Genetic etiologies.
Because
I
most of
would
the
like to
time,
make a comment there because, you know, it's an important element to realize that this was a retrospective study. So this will happen collecting cases over a number of years, and the access to genetic testing has been not uniform. We have started with karyotype, then evolved to microarray, then to panel, now to the whole exome sequencing. And you saw that the yield was about 34% of diagnosis, but 70% of the diagnosis came from the use of next generation sequencing. So what tells you is that actually this is an underdiagnosed cohort because we did not do the same test in all the patients. So it will be very important to follow a cohort now prospectively and be much more uniform and thoughtful about doing genetic testing. So I think that, you know, there was a theme here in this presentation. Many of these patients have a genetic presentation. Actually, it's very important for us to identify, is this an isolated disorder, isolated to the heart in this case, or is this a systemic problem? Because a systemic problem would have implications for the way the patient will fare, and obviously implications for the decision in management that the patient and the team makes. So it's important to understand the complementarity between different people, because in prenatal, really, we do not really see the patient. So we have incomplete information about phenotype. So then a test that is not hypothesis-based, like the whole exome sequencing, is probably the most appropriate test.
But syndromes are excluded, right?
Syndromes are not, well,
are
are not
not.
excluded because we do not know that when we test patients. There is not a correlation between being having an isolated finding in prenatal and or having multi-system findings and the chance of having a genetic diagnosis. You can have multiple congenital anomaly and no genetic diagnosis, and you can have an isolated system and a very powerful genetic diagnosis. So I would say the best is to consider testing. I strongly recommend testing.
I have a question for Simon. We've over the years kind of evolved in terms of discussions around, and certainly we're super thrilled to have you guys involved from a fetal perspective, and really it's helpful for the family to meet the team who's going to be primarily responsible for following them longer term. What about prenatal listing? What are the sort of caveats there? And I think that's worth discussing because there have been times that we have maybe even listed and then have kind of said over time, maybe it's not the right thing. I'm just curious, especially for the really bad end of the spectrum.
Simon?
Oh, is Simon off? Maybe Simon had to go. So, I mean, the long and the short of it is generally we wouldn't list prenatally because it's often hard to know what the full spectrum of these babies is. And some of the conditions we've not diagnosed prenatally, like mitochondrial disorders, some metabolic disorders. And so not having all of the data, we've been very cautious. Having said that, we've had many discussions. If you had a familial cardiomyopathy that is really confined to the heart and really bad for the fetus, and you can get the baby to those cut points of 34 weeks and above for delivery and a weight of 2.5 kilos and above for all the mechanical supports and also potential for transplant, we would consider listing for transplant, but not usually before 34 weeks because we offer them other things and because of the risk of that we've seen with respect to transplanting much smaller babies. Sorry about that. I thought he was still on.
No, it's beautiful, Lisa. I mean, the message here from your study, and it's a beautiful study. Now you've lumped them all together: the dilated, the non-compaction, and the hypertrophic. Right? Now, from my understanding, but you put that the number one dilated, number two is HCM, number three is the non-compaction. From another study, the non-compaction was number two. Is this something new because the machines are better, or why is that?
No, it's a reason for central site review of echoes because there's inconsistency in what cardiologists from one site to the next is calling this. One of the most interesting things is the fact that as Shilpa's reviewing these, most of those diagnosed as dilated cardiomyopathy, in fact, have a lot of features that look very suspicious for non-compaction. And maybe it's a fetal manifestation of a dilated cardiomyopathy. I don't know, but it's interesting. A lot of them have that sort of weirdly hypertraveculated LV. And so we've kind of gone back and forth as to where you actually put them. And so there's the other thing that's interesting is there are genetic abnormalities that we know have are responsible for a whole spectrum of these diseases. From an example is MYH7, hypertrophic cardiomyopathy, dilated cardiomyopathy, non-compaction. So almost those phenotypes sometimes may be messy even within the same kind of global or gross genetic mutation that kind of throws a wrench in the whole thing. But that's what we're kind of trying to better understand and also have a more uniform way that we look at these and say, this is where we're going to put them anyways, and how do they fit the genotype if there was
So what's the message now for give me numbers in echo? It's hypertrophic cardiomyopathy because, as you said, people call it differently, right?
So wait till the next, wait till the next paper. It's coming.
Okay.
But we're
because
reviewing at least.
For as you said, it looks to me like non-compaction. Well, you have to measure the length of the villi and the ratio and whatever, and do MRI postnatally, but antenatally. There's a lot of I think it could be. I think it could be. We don't have really standard, and that maybe made it different different results so far. Thank you so much. It's beautiful. The way any treatment offered antenatally for dilated cardiomyopathy?
Yeah, we talked about them. Maybe Luke can just
And in the study, it's retrospective. Okay, sorry.
yeah, so we'll have data. We'll look at the DIDGE question, and there have been a few other medications for arrhythmias and things like that. So we'll have a look at those and probably be evaluating those with the echo review that Shilpa's doing.
So what is the take-home message from the team today? I just want to thank you for coming. It's a bit late, but thank you so much for really offering to teach the world. So what's the take-home message? I mean, Lisa is of course, the leader, but everyone has to tell us what is take-home message from his presentation. Take-home message? Who wants to
Luke?
start?
Maybe Luke.
Take-home message, I think that cardiomyopathies can be really obvious, but also really subtle. And I think having a routine approach to looking at sort of systolic and diastolic function is likely to pick them up when a more simple sort of approach may not.
Thank you. Shilpa? Oh, sorry. Lisa, you want to comment?
Nope, I was going to offer it to Shilpa,
Okay.
sorry.
Shilpa, please.
Yes. Yeah, so I would agree with what Luke has said. Fine, picking for the subtle clues is important, closely following them up and watching for progression, and importance of genetic testing, because as I said, with the hypertrophs, we can consider trametinib in the postnatal period.
So you said subtle but deadly. I like that. Right? So this is the message of saying subtle but deadly. So don't miss anything, even if it is, and the message also bring them back, right? A lot of people have big clinics, they don't want to bring them back, so bring them back. If you're not sure, if you're not happy, if anything happens, yes. Sue, please take home message.
Okay, well, from the maternal fetal medicine perspective, I just want to say it's a multidisciplinary approach. So obviously we're focused on the heart, but assessing for extra cardiac anomalies that may provide a clue to a potential genetic cause, offering the genetic testing, and maybe using the MFM colleagues to help inform decisions on mode of delivery, timing of delivery.
We cannot live without MFMs, but they don't like us a lot. Decisions as yours.
We love our cardiology colleagues here. So
we're only consulted. We're only consulted, not take over. And Lisa, take home message.
So the other part of it, and I agree completely with everything that's been stated, in addition to having an approach to evaluating these patients, to the workup after, and then the surveillance, how frequently you're going to follow them. And you develop this within your program so that there's consistency and you don't miss things. An example is like doing echoes. It'd be very important if mom herself had a myocardial process and she's going to deliver this baby and you miss that opportunity to have a look and be able to anticipate. So that's one of the first things we do is an EKG and echo in mom, get those and EKG and echoes in the family's cascade testing. As I said, 7% of our patients ended up with affected family members and the baby was the first case. So that's really important. And other tested, the genetic testing, et cetera. So forming kind of a
genetic testing is important. What would you do, Wes, nowadays, or what? Because we keep saying people, different parts of the world have different
and there's some limit. Yeah, exactly. There's limitations. I think with our experience, Wes is now up there right away. And the problem with Wes for us is it takes us a little bit of time to get it back. So we really like to have that data before the babies are born and really try to convince the families to do genetic testing, because that can be very helpful in planning what you can offer, what our team's willing to do, and that way the families are really prepared. An example is if there was something that really is more diffuse, metabolic, mitochondrial, whatever, if there's more diffuse disease, in fact, we're going to be really not keen to be listing these kids for transplant. In which case, do we offer a VAD mechanical support if we don't have an end and these babies are getting sick? So all of that is part of the discussions that we have with our colleagues even before these kids are born, and having the genetic diagnosis, if we can get it early and have as much information as possible, both the family and the team are going into managing this baby with our eyes wide open, which is the most important thing.
Beautiful. I had a, you didn't talk about X-linked. I had two boys with cardiomyopathy. One I diagnosed antenatally, and the mother was a nurse, and she said, oh, he's like his brother. So, but X-linked is there or not there?
Well, it's the first case that we presented, I think you missed.
I'm sorry.
Was an X-linked diagnosis of what's called no-no, and it led to being contributed to a collaboration, a multi-international collaboration on a handful of these babies better understanding this diagnosis, and cardiomyopathy is part of that picture. So
And
it was an
prognosis is
X-linked
good?
called
Prognosis is good or not?
Probably
for
not
X-linked?
with the cardiomyopathy, not with the spectrum that this baby had. There are other issues like neurodevelopmental outcome problems, but yeah, so we're still learning. I mean, it's really an area that we're still learning, and especially now that we have access to whole exome sequencing in particular, we're learning a lot about sort of what do these genes mean and how are they manifesting and what will that mean for those babies from a cardiac perspective, but also from a non-cardiac perspective long term, all of which is really critical to counseling.
Last question, because I know that you have to go. Advanced echo imaging has a role in prenatal diagnosis of cardiomyopathy, other than 2D, whatever color with the standard. Anything new?
Great question. So we put the Fetal Heart Society put a statement on kind of basic evaluation of fetal heart, and we did include things like strain. We did include all sorts of other measures. I think that we still are learning. I think the bottom line is exactly how they fit and everything. We still don't know. What we showed you was the kind of the simplest basic I think that you should be doing, at least doing those measures. But some of the newer, not so new technologies, to be honest. I mean, all the strain work and even the tissue Doppler work, and we've got tissue Doppler data. Just it's not routinely done out there. We just don't know how it links to the evolution of disease, what it means, and are there predictors? I think there's just not enough data. Some of it's because the numbers are small at any one institution, and again, calls for a more prospective look at fetal cardiomyopathies with some of the newer testing that will be really helpful.
I want to thank you all for coming. I want to thank Lisa, and I want to re-apologize for coming late. As I said, I had an emergency, and I just want to say for our audience, this is a recorded webinar. You can always find it on YouTube, and I hope we see the Stroley and the University of Alberta team once more very soon to tell us about the updates on this. And also for the Fetal Heart Society, I just want to say there's a global committee, whoever is interested in joining worldwide, to share their knowledge and have active research with the group. I think Lisa is part of the Fetal Heart Society and part of the research, top of the research group. Thank you, and thank you so much, and have a good day. And we say here good night to the people in the Middle East. Thank you.
And thank you. Thanks, Shilpa and Luca as well. Thanks, Rima, for having us.
Thank you. Thank you. Thank you.